Good morning, everyone, and welcome to today's webinar. Today, we're going to talk about building benefits to complement original Medicare, how to use some of those Medigap policies to support your clients' journey through Medicare Parts A and B, and then a little bit of some Part D in there as well. So welcome. My name is Chelsea Smith. I am a learning and development specialist here at Action Benefits, here to help you learn as much as you can about the industry and support your selling processes. Today with me, I have my friend Kevin. He's going to help me answer some of your questions that you might have. Kevin, if you would like to introduce yourself for everyone.
Hi, my name is Kevin Geralman. I'm an account manager on the individual team, and I'm here to help you with anything that you need.
So let's get into the outcomes of today's sessions, what it is we are going to try to accomplish today in our hour. So we have 4 things we are going to try to teach you today. First is hopefully by the end of the session, you can explain the coverage provided by MedSup and Medigap policies. You can identify guidelines for enrolling, switching, and dropping MedSup policies. You can describe the costs and functions of Medicare Supplement policies. And you can explain key elements of prescription drug plans. So like I said, hitting up a little bit of that Part D today as well. We can go ahead and get into our content. So what is a Medicare Supplement plan, also known as a Medigap plan? You're going to hear both of these words kind of interchangeably throughout the presentation and throughout your time that you spend selling and working with MedSup plans. So a Medigap or a Med Supplement policy is a health insurance policy sold by private insurance companies to fill in the gaps in original Medicare plan coverage. You'll see a little bit more of the details of what those gaps are later on. But as we all know, Medicare's Parts A and B don't cover everything. So supplement plans are meant to supplement, hence the word, those gaps and fill them in for some additional premium price. These policies help pay some of the original costs as well that original Medicare doesn't cover. If you are in original Medicare and have a supplement policy, then your Medicare and supplement plans will each pay its share of covered health costs depending on what policy covers each item. So supplements or Medigap, these are really interchangeable terms. As of 2023, so as of today, the carriers that we offer to work with at Action that have MedSup plans are Blue Cross, GTL, Humana, Priority Health, UHC, McLaren, and Medico. New to that list as of a few weeks ago is Humana, so listen up for that one, right? A Medicare supplement insurance policy helps pay some of the original healthcare costs that original Medicare doesn't cover, like we said before. These are usually things like deductibles, co-payments, and co-insurance. This is again going to depend on which Medicare supplement plan you purchase, but those are usually some of the baselines. And then some supplement policies also cover medical care when traveling outside of the US. If a beneficiary is enrolled in original Medicare and buys a MedSup policy, their Medicare will pay its share of the Medicare approved amount for covered healthcare costs. And then supplement policy pays its share. For those of us who are more seasoned, we know that this is payer status. Medicare does usually pay before MedSup plans will pay, and then MedSup will cover after. We'll talk about that a little more later. So in other words, original Medicare pays primary to the supplemental plans. And like we said, the most of the things that are covered in these MedSup plans are deductibles, copays, and co-insurances, and a little bit more mixture of other things, again, depending on which supplement plan you choose. So the biggest 8 things to know about supplement plans are as follows. I like to just put all of them on the screen from the get. So Medigap policies do not substitute a beneficiary's needs for Part A and B. They still will need original Medicare in order to sign up for a Medigap plan. So the process of getting a supplement plan goes kind of like this. You would sign up for A and B, and then you have some time after signing up for A and B in which to sign up for a MedSup plan. So you can't sign up for them all at once. You have to be completely ready with Part A and B first, and then get your sup plan. So therefore, Medicare pays first, or in other words, supplemental coverage does not replace original Medicare. It works with it. Anything it does cover will be paid for by Medicare first, and then Medigap will come in after if any additional coverage is available in that Medigap plan. Unlike other types of coverage, Medicare only covers one person at a time. So therefore Medigap policies also have a 1-to-1 ratio. Supplement policies are purchased from private insurance carriers and are secondary. Members pay monthly premiums for supplement policies in addition to Part B premiums for Medicare. These plans are all standardized. So the plans will be the same. If they have a certain name to them, they will be the same across carrier. The only difference will be the price and any additional benefits that carrier might tack on to that med sup plan to make it more palatable, right? So there's nothing that will be taken away from med sup plans between carriers. There'll just be more added, and the price is the only difference. Any standardized supplement policies, so those policies we just spoke of, are guaranteed renewable, meaning that every year you can renew it. It can't be taken away from you once you've signed up for it. Supplemental plans sold after January 1st of 2006 don't cover prescriptions. Part D plans are necessary for drug coverage. So that's why we're going to talk about Part D a little bit today as well. And supplement policies are not allowed if you have a Medicare Advantage plan. We talked about some of those in the earlier webinars that we did last week. We're not going to talk about Medicare Advantage plans here today, but the only thing you really need to know about Medicare plans in order to understand this webinar is that you cannot have a Medicare Advantage plan and a Med Sup plan simultaneously because they tend to overlap. It is illegal to sell a Med Sup policy to someone who has a Medicare Advantage plan. So keep that in mind when you are out there making those sales. So what is not covered? Supplemental policies generally don't cover these options, like long-term care, private duty nursing, prescription drug coverage, vision care, dental care, and hearing aids. However, many carriers do offer dental, vision, hearing buy-ups that pair with Med Sup plans. But these are totally independent of any buy-ups for Medicare Advantage plans and totally independent of the sup plans themselves. They would be purchased like separately and are not the same buy-ups that would be included with a Medicare Advantage plan. So two different, same idea, you're still buying up, you're still adding additional coverage like we talked about a little bit earlier to that plan, not necessarily the same though. They're two different types of supplement plans. So while there are other types of plans that are designed to create more support for a beneficiary's primary healthcare product, these plans do not mix with Medicare supplement plans. If a person has any of the plans that are listed on the screen, then a Med Sup plan is not for that person, and they would have to find a additional type of way to supplement their care if they so chose. And a Med Sup plan will not interact with these other plans. I'm not going to read them to you. You can read, but so if they have any of those, the only one I'd like to mention is any Medicare Advantage plans, right? Because those are illegal to sell to someone. Or I'm sorry, a Med Sup plan is legal to sell to that person if they have a Med Advantage plan, right? Okay, so that wraps up the first little section of our time here today. I have a knowledge check for you. Before I get into the knowledge check, Kevin, is there anything you would like to add that I missed before we would continue to the knowledge check?
No, nothing. You're doing a great job covering everything.
Oh, thanks. I do my best. Okay, so I'm going to throw our first knowledge check up on the screen here. So how would you best describe Med Sup plans to someone? All right, awesome. It looks like everyone got this one right. So great job retaining the information I was giving out to you guys today. So Medicare supplement plans are secondary, awesome. And they cover some or all of cost sharing depending on what item it is that the beneficiary is looking for, right? Because some of that is going to be covered by original Medicare and some of it is not, and that stuff that isn't at all, that's going to be where your Med Sup plans come in. So great work, guys. Let's keep on keeping on. So Medicare supplement policies, enrolling, switching, and dropping. So beneficiaries will probably want to enroll in their supplement plans during their initial enrollment period or their Medicare Supplement open enrollment period, which is after they enroll in parts A and B. During open enrollment is also an option. They can enroll during that as well, but it's probably in the beneficiary's best interest to sign up as soon as possible, despite the fact that Med Sup plans don't have late enrollment penalties. So normally when we talk about when a beneficiary should enroll in their plans, we say right away, as soon as possible, or after they lose their group health coverage, because we don't want to see them having to pay those late enrollment penalties that are associated with parts A, B, and D. But Med Sup plans don't have those late enrollment penalties. So not really a problem there, but the problem that we are going to run into if we sign up late for our Med Sup plans is going to be that guaranteed issue, which comes into play. If they miss their original windows, they are able to sign up outside of open enrollment, but some of those plans might not be guaranteed issue, meaning that the beneficiary might have to undergo medical underwriting, which can possibly raise the plan's premiums if the beneficiary lives with any medical conditions. It could also mean in some cases that Medigap policy is off the table completely for that person, depending on how that medical underwriting shakes out, right? So if that person goes through underwriting and has a lot of medical conditions, that would make it very expensive for that carrier to keep that beneficiary on the policy. They might not be able to get that policy at all, or the premium is going to be a little higher. So maybe it is in the best interest for that person to sign up later, but monetarily and at face value. But if they end up winding up with one of those conditions, wanting to switch to a Med Sup plan, that savings might be eaten up by how much more expensive that premium would be now that we've added on that money based on the non-guaranteed issue that plan might have. So good thing to keep in mind for your clients who might be looking to hop Med Sup plans or delay their Med Sup plan enrollment. So like we brushed on the previous slide, the best time to do that to enroll would be during open enrollment period. So the open enrollment period for Med Sup plans would be the 6-month period beginning when beneficiary is both 65 and enrolled in Part B. That is the only time where these plans are not subject to any medical underwriting at all. And during that 6 months of time, their application cannot be denied for any reason. There can't be any waiting periods, elimination periods, or probationary periods that can be included at that point. Beneficiaries who are under 65 and eligible for Medicare due to ESRD or disability can apply for Med Sup policies when they are eligible, but the choices might not be all encompassing within all plans that are offered by any carriers, because carriers are not required to offer all plans that they have available to everyone if they are under 65. So for instance, if Humana offers A, F, and N, if I remember correctly, Humana would not need to offer all 3 of those to people under 65 with ESRD or disability. They just have to offer something. And usually it's plan A, if I recall. It might not always be plan A, but it usually, I believe, is plan A that they offer to under 65 people. So if someone has ESRD and for whatever reason really wants plan like K, that might not be an option for them, because carriers are not required to offer all of the Med Sup plans that they have to those under 65. So keep that in mind if you have an ESRD person or a under 65 disabled person looking for a Med Sup plan. So those over 65, like we just said, are not the only ones eligible for Medigap plans. Those with ESRD and other disabilities also are eligible. Michigan requires that carriers provide at least one SUP plan, but not all of them. So keep that in mind. Michigan is only one. I can't speak for Ohio, Indiana. I don't recall off the top of my head what those are, but I know it's at least one. And like I said, I believe it's usually plan A that's offered. So guaranteed issue rights. Guaranteed issue rights means that a person cannot lose coverage due to certain changes in their health. So I like to have it just all up there. A person would apply when the beneficiary experiences a change in other health coverage, whether they lose their group coverage, their plan leaves their area, they quit their Med Advantage plan, their Medigap carrier goes bankrupt, or their Medigap or MA carrier commits fraud or misleads the consumer, then the carrier must sell a policy to that beneficiary that covers all pre-existing health conditions and does not require medical underwriting. All of these things at the bottom where it says carrier must, those also apply during that 6-month period surrounding turning 65 and having Part B, like we mentioned earlier. But this also, guaranteed issue rights also apply in these kind of niche circumstances here. Generally, the periods last 63 days from the event itself. More specific information can be found at medicare.gov. I know these are kind of like one-off circumstances. Hopefully there's not a lot of Medigap carriers committing fraud and going bankrupt around where this is a thing you're dealing with a lot. But if you do, you get 63 days after that event to put the person on a different plan. So a non-guaranteed issue right would happen in these situations. So either outside of an open enrollment period or outside of a guaranteed issue period. Carriers can underwrite and can ask medical questions, and they can straight up deny coverage to that person if they don't meet the criteria that the carrier would like. So they can underwrite up to age 80. They can underwrite where the person lives, the gender of the person, whether or not the person uses tobacco can also be included in that medical underwriting. There are 4 reasons that someone might switch plans outside of that guaranteed issue time. Maybe they're paying for unneeded benefits. Maybe they need more benefits. Maybe they want to change carriers, and there might be a lower cost it's associated with switching if that person can pass medical underwriting. Maybe one carrier has it for cheaper. Like we said, carriers can offer the different plans at different rates. There is also something called a free look period if you are looking to switch plans. Free in this context doesn't mean that the contract is free, so it's not that you don't have to pay for it. It's just that you are free from signing a contract or free from obligation to stay for the rest of that year. You just have to look at it. You could just pay for it for that month and try it out for a month, kind of like Mammoth Video, showing my age here for a second. So individuals have 30 days to decide if they want to keep a new supplement policy. This is called your free look period. The 30-day free look period starts when they get their new supplement policy. Individuals need to pay premiums for both med subs for that 1 month. So it can get a little pricey for that month if you want to do that trial. Individuals should not cancel the previous med sub policy until they have decided to keep the new sub policy. On the application for the new sub policy, they will have to promise that they will cancel their first policy if they choose to keep the new one, and beneficiaries cannot keep both for longer than 1 month. Of course, staying with the old med sup plan is also an option, and the beneficiary has to drop at least one of the 2 plans. You cannot keep both. One of the 2's gotta go. So if you drop a sub policy, policies are guaranteed renewable except when you don't pay one of the premiums for the 2. The information on the supplement application was found to be untrue, or if the carrier goes bankrupt. Policies bought prior to 1992 may not be guaranteed non-renewable. Carriers must have state approval to terminate the policy, and individuals have the right to purchase another one if they so choose. I wonder if there is anybody out there who still has a med sub policy from 1992. So that's a long time. That's like 30 years of being on a med sub plan. They'd have to be like 110, I think. I don't know. Don't ask me to do math. That's why I got into health insurance. Okay. So hitting our next knowledge check here. As is tradition, Kevin, is there anything you would like to add before we keep on keeping on here?
I just want to point out that if you do have a client who is applying without guaranteed issue, that Blue Cross is the one carrier that will accept them no matter what, whereas other carriers can just outright deny them.
That is good to know. So if you have if you do have a client that you know for a fact has one of the medical conditions on the underwriting sheet that might deny them or might raise their premium, Blue Cross might be a good option for that client. So nice ad. I love that. Okay. So now let's check question number 3. James turns 65 last month and has enrolled in Medicare Parts A and B. He is concerned that his type 1 diabetes may impact the premiums he pays for his med sup plans. What might you say to reassure him? All right, so yes, looks like everyone got that one correct. Love that for us again. A is the true answer. Since he is newly eligible for Medicare and has enrolled in A and B, he is within his open enrollment period and has guaranteed issue rights. When enrolling during that enrollment period, carriers might not or cannot use any underwriting to determine the rates, and those with pre-existing conditions and those who are in good health will be charged the same premium, all else being equal. So let's go right on to the policy function and costs of these med subs. So now that we have seen the whole of the Medigap menu, I do regret to tell you that some of these plans have been 86ed for a large portion of the market. So if you look at this chart here, med sup plans are just labeled as letters. There's A through N, with some of them completely removed from the chart. And some of them are kind of on their way to being phased out. Plans C and E are currently being phased out and are no longer able to be sold to anyone who was not eligible for Medicare before 2020. So if you have someone who's a little older looking to move med sup plans, they are still eligible for C and E. However, everyone else who is turning 65 now cannot get C and E. They would have to stick within the A, B, D, G, K, L, M, N process here. So gotta remember my alphabet, and then I have to skip some. It's a whole thing. So keep that in mind while you are looking, especially for your older clients, because a lot of them do love that C and E. From my understanding, they love those plans. So don't sleep on them if you are someone who's previous to 2020 and can utilize them. Otherwise, they would have to stick with the ones that are on the screen. So let's get into what carriers that we work with still carry, what plans they do carry. So Blue Cross has a lot of them available. Blue Cross offers A, C, D, F, high deductible F, G, high deductible G, N, and or G and N in Michigan, excuse me. So those are on the screen right there for Blue Cross. So GTL offers A, B, F, G, and N. Humana offers A, G, and N. McLaren often offers A, C, D, F, G, and N. These are all in Michigan, by the way. I don't know if I said that or not, but these are all in Michigan. If you're in Indiana, Ohio, I can get those for you if you need them, but these are all just Michigan alone. And then we have Priority Health. Priority Health offers A, C, D, F, high deductible F, G, high deductible G, and N in Michigan. UHC offers all Medigap plans except for M. M is in Michigan. And then we have Wellaby, which used to be Medical. Oh my gosh, I called them Medical earlier. I'm sorry, it's Wellaby. So it used to be Medical, now it's Wellaby, just like Twitter used to be Twitter, now it's X. So Wellaby offers A, C, D, F, G, and N, as and McLaren offers those ones as well. So here we go. Here is the chart that shows all of our carriers that Action works with and what they offer. So if you are someone who wants to be appointed with everybody that we work with and work with Action all day, every day, highly recommend that for you. Then this is the chart for you. These are the policies that you could sell potentially with all of those carriers. That's to offer. So now let's check really quick before we continue. Which of the following statements are true? I put the picture into the poll itself, so hopefully you can still see it. Let me know if you can't. But which of the following statements are true about this Medigap plan? All right, it looks like a lot of us got this question correct, and that is awesome. The two that are true are B and C. So members with effective dates after 1/1/2020 are not eligible for plans that pay for the Part B deductible. That's kind of why a lot of people really loved that plan, because it was also paying for their Part B deductible. That's no longer, those two plans, C and F, are no longer available to someone unless they were born previous or turned 65 previous to 2020. So if you are going to sign up for a Med Sup plan, unfortunately, you are going to be responsible for your Part B premium. I'm sorry, deductible. All Med Supplement plans will cover at least part of the coinsurance for Part B services. That is correct. All of them do that to some extent. So awesome work, guys. So I promised you to talk about prescription drug plans, and that is the section that we are getting into right now. Because we are looking to supplement our original Medicare, that would be what Part D is designed to do. So let's get into that. So Medicare Part D is considered prescription drug coverage. I always think D for drugs. If you choose original Medicare and you want prescription drug coverage, you must choose a Medicare prescription drug plan. Usually you're going to end up paying a monthly premium for Part D for these plans. These plans are run by private companies that contract with Medicare. You cannot sign up for a Medicare Part D plan through CMS. They are all ran by private carriers, private companies. Medigap coverages will not have drug coverage. Med Sup plans do not have drug coverage. So if a beneficiary wants drug coverage, he or she is still able to get it. You can sign up for Part D, but it will have to be Part D, right? You will not get any drug coverage with a sub plan. Medicare contracts with private insurance companies that offer prescription drug plans to people with Medicare. Everyone with Medicare can get Medicare prescription drug coverage by enrolling in a Medicare drug plan. Unlike Medigap plans, Part D drug plans may come with a late enrollment penalty if you join later. You might get this coverage from a Medicare Advantage plan with prescription drug coverage. But to join a Medicare Advantage plan, you must have Parts A and B. And remember, you cannot have a Medicare Advantage plan and a Med Sup plan. Costs for these plans are going to vary depending on what plan you choose. And like we said before, most will pay a monthly premium for that coverage. You'll also pay a share of the cost of the prescriptions, including the deductible if the plan has one. Some plans don't. Co-payments and co-insurance. Medicare drug plans have to provide at least a standard level of coverage set by Medicare. However, some of these plans might offer more coverage and additional drugs. And then, as you might imagine, more coverage means higher premium. But that's the gist of Part D plans there. So Medicare Part D is not automatically deducted from Social Security benefits. So that will be paid separately, unlike Parts A and B. Part D is optional, but like we said before, just like Part B, you will have to pay a lifetime penalty if you sign up for it late. And it is also subject to IRMA. So IRMA would be deducted from that, so can be deducted, I should say, from that Social Security benefit, and does not have an impact on the premium charged by that carrier. So it will be charged, that IRMA charge will be separate from that premium charge. And like this says, usually deducted from Social Security benefits. So speaking of premiums, beneficiaries pay only the plan premium if their yearly income 2 years ago, so for us in 2022, for plan year 2024, was $97,000 or less for an individual, or $194,000 or less for a couple. If they reported a modified adjusted gross income, or MAGI, as it's called, of more than $97,000, individuals and married individuals filing separately, or $194,000 if they are married and filing jointly on their IRS tax return 2 years ago, They'll have to pay an extra amount for their Medicare prescription drug coverage, called income-related monthly adjustment amount, or IRMA, like I spoke of earlier. They will pay this extra amount in addition to their monthly Medicare drug plan premium. If their income has gone down due to any of the following situations and the change makes a difference in the income level that Social Security would consider, they should contact them, and explain that they have some new information that might change that IRMA decision. Other things to consider is marriage, divorce, being widowed, discontinuing work or reduced work hours, if their spouse lost income producing properties due to a disaster or something beyond your control, if they experience a termination of a pension plan, or if their spouse received a settlement from their employer due to the employer becoming bankrupt, closing, or reorganizing. So you're not married to IRMA. You can kind of avoid paying it if your circumstances change, and you can dispute IRMA if you feel that it is not applicable to you. So there are some cost sharing phases in Part D. There are 4 as of right now. So in stage 1, there's you would pay the deductible. You would pay the full price of all medications until the deductible is reached. And then some Part D plans don't have a deductible at all, and you would start in stage 2. No deductible can be higher than $545 in 2024, but each plan can vary. And then, like we said, some don't have a deductible at all. So they might not necessarily be $545, but that is the highest that the deductible can be in Part D. Once you reach stage 2, and like we said, some people might skip directly to stage 2, you remain in this phase until the total cost of your drugs paid for by both you and the carrier reach a predetermined amount. For most plans in 2024, after the initial coverage period ends, and after the drug costs have accumulated $5,030 in total. This is not what the beneficiary will end up paying. This is a combination of what the beneficiary and the rest of the costs combined will cover. So once that $5,030 is hit, beneficiaries are only responsible for the 25% of their drug costs, while the manufacturer and Medicare will pay for the rest. The cost is then applied to the out-of-pocket max. Once that out-of-pocket max reaches $8,000, then we're heading into the final stage, that catastrophic coverage, which I think it's only like 10% of beneficiaries end up hitting that 10%, that $8K and getting into this catastrophic phase. But there is some new changes to the catastrophic phase. Medicare will be responsible for paying 95% of that. There's no more than 5% coinsurance, and Part D plans will cover 20% of the drug costs instead of that previous 15%. Once you're in this phase, until the end of the year, and then it restarts in the beginning of the next calendar year. So lots to remember during in Part D coverage phases, but it does end up winding up being usually beneficial for those involved to get a little more of that extra payment. So there is a late enrollment penalty to Part D, like we mentioned earlier. If beneficiaries don't enroll when they're first eligible or have a break in credible coverage of more than 63 days, they will end up paying a penalty for Part D. LEPs are determined annually. They're based on 1% of the average national base Part D premium, because like we said, carriers establish the price of the premium, so there's not just one number. It is a average that is used to formulate the penalty. It is compounded for each month the person was eligible and didn't enroll. It continues for the entire duration of the time that the person is covered by Part D, and then that is added to the Part D plan premium. Is paid until that person no longer has Part D. So Part D changes as a result of the IRA. So signed into law in August of 2022. These are the planned changes for Medicare. If you would like to learn more about the Inflation Reduction Act, we do have a video Medicare in Minutes. They're a great source. I'm a little biased because I made it, but it is a wonderful video to learn about some of the changes that are going to occur over the next couple of years with the IRA and the drug coverages. So we already are involved in some of these already in 2023. If you have a person with insulin in your life, you know this already, and an elderly person with insulin needs, you already know this. Or if you've gotten vaccines lately, if you're a beneficiary, you know this already. Some of these have already occurred, but they are going to continue to occur up through technically till 2029 when some of those negotiations are wound up. So, and we are currently in the process of seeing how that's shaking out now with those negotiations for those 10 drugs that were chose. And I went and looked them up. Some of those were crazy expensive. Oh my goodness. So no, I don't blame anyone for a minute for wanting those negotiations to come through and get some cheaper drug prices. So, that was a lot. Okay, knowledge check before we keep on keeping on. We are almost done here. So knowledge check, unless Kevin, you have anything you would like to add?
No, nothing.
Perfect. So question 5. Jasmine takes several maintenance medications to help control her cholesterol and blood pressure. She'd like to explore prescription drug coverage to reduce her out-of-pocket costs. Which of the following statements are true for Jasmine? Okay, so technically, C is not correct, but that's because the out-of-pocket max on there is last year's out-of-pocket max. I kind of tricked you a little bit there, so don't feel bad. But the rest of them are technically all of them. If you're going on a basic level, I guess I should say, all of those are correct. The only reason C would be incorrect is because that number is now 8,000, not 7,050. But the rest of them, those A and B are completely correct. And then C, I was messing with you a little bit, but if you put C, I totally understand because that was just last year's out-of-pocket max. So all 3 of those are correct on a basic level, with C having a little bit of a trick there with the old out-of-pocket max. So initial enrollment periods for Part D. So while MedSup accounts might have different offerings for disabled people or people with ESRD who are under 65, Medicare Parts A, B, and D are different. Disability eligibility for Part D does not make different coverage for that person. Even if you only have Part A, you are still eligible for a prescription drug plan. So if you don't choose to enroll in Part B, you can choose to enroll in Part D if that's what you want to do without having Part B. So I'm not going to read the whole chart to you, but those are kind of the nuanced, more niche situations in which someone could sign up for Part D outside of their normal times. So there are some enrollment periods every year associated with Part D. October 15th through December 7th, which we are in right now, the annual election period. The changes made during the AEP take effect on January 1st. A person can join a Medicare prescription drug plan, switch from one to another, or drop their Medicare drug coverage completely. And from January 1st to March 31st, this is the Medicare Advantage open enrollment period. You are allowed to make one change during this period. Changes will take effect the first of the month after that plan, after the plan gets a request. So if in a Medicare Advantage plan, a person can switch to another Medicare Advantage plan, this person can disenroll from Medicare Advantage plans and return to original Medicare, and allows for a joining of a Medicare prescription drug plan. If they're enrolled in a Medicare Advantage plan during their IEP, they can change to another Medicare Advantage plan or go back to original Medicare. So those are the enrollment periods that might affect someone with Part D. So there are special enrollment periods for prescription drug plans. So if the reason would be for this, either you are losing other credible prescription coverage or other exceptional circumstances, like we kind of talked about earlier, those like bankruptcies, such as that. So one last knowledge check for you before we wrap things up for today. Under which of the following circumstances will Jasmine be able to enroll in a Medicare Part D prescription drug plan? Okay, so if you answered A or B, you were correct. So initial enrollment period is when you can sign up for Part D the first time. That's usually when a lot of people choose to do so. And you could also sign up during your original Medicare open enrollment. The only one that is incorrect is the anytime during the calendar year. You're thinking of med subs in that situation. So our key points for today, if you got anything out of today, here's what I hope you got out of it. Original Medicare, Med Sup, and Part D plans combined together to provide more comprehensive coverage for your members. It is best to enroll for each of these during the initial enrollment period to avoid late enrollment penalties, unless it's Med Sup, you don't have those Med Sup, and ensure continuity of benefits. Combining these types of coverage might be helpful for members who prefer to pay upfront for care, especially those who may want to budget on a fixed income. So there are lots of different options for your clients out there to get a Med Sup plan and a Part D plan to add additional coverage onto their Parts A and B without getting one of those Med Advantage plans if they are not interested in a Med Advantage plan. So hopefully that's what you got out of today. That is about it for what I have for you today information-wise. If you have any questions, please feel free to throw them in the chat right now. We got done with 3 minutes to spare. Love that for us. So I did stay within our 1 hour time confines here. If you have any questions, drop them in the chat. Otherwise, I appreciate your time with me today.